This is the EMS Research vlog and podcast where we talk about the research-related issues that matter to those who work or study in the area of emergency medical services. Your host is Bram Duffee, who is a paramedic and communications professor.
Welcome to the EMS Research vlog and podcast from the studio here in Houston, Texas. I want to start out by drawing your attention to our website where you can check out anything that's show related when you go to professorbram.com. That's professorbram.com. At the website, you can find the latest show, see my talks in the media, order the latest book, and also look at how to participate in research. This is all stuff that can help you grow in the world of EMS research. Like right now, I have a research study open for first responders. So if you don't mind being interviewed by me, then go to my website at professorbram.com and click on the current research tab to apply. Dr. Nick Cochran-Caggiano, he is an EMS fellow at the Yale New Haven Health, where he not only provides expert care as an attending doctor, but he dedicates his time to mentoring and education for other doctors at the Yale School of Medicine. So his research focuses on out-of-hospital cardiac arrest, pediatric ambulance transport, and public health. And so before beginning his medical career, he spent 7 years as an EMT in Massachusetts and New Hampshire, where he served as both a field training officer and a clinical educator. So this type of experience sort of drives his dedication to advancing emergency medicine as a researcher, an educator, and a physician. I'm just thrilled to have you on the show today. Can you please tell the audience just more about yourself and say hey?
Yeah, so I kind of began my time as an EMT in college, initially as frankly just as a job, but then using that to kind of develop experience and identify the things that I was looking for in a future, frankly, looking at the pros and cons of the field and seeing how I thought I could make a difference in that. And so went off to medical school in Albany, at Albany Medical College, did my residency, so 3 years of additional training in Syracuse, the state university, and now doing an additional year of kind of voluntary training at Yale to kind of complete that picture. And then I will be going up to Dartmouth as an assistant professor and both a faculty member and an EMS physician up in their system in New Hampshire.
So congratulations on that.
Thank you.
That's your career is impressive. And I think about other people that I know who are in EMS and that I've known and have become physicians. And I have to be honest with you, it's really rare that I see emergency physicians caring much about research, because it seems like it's such a hands-on area, right? And when I say care about research, I mean conducting their own. But I found you because of the research that you did. And I'd like to, talk about a couple of those articles today.
When I was working on the road, I had the fortune of being in a system where there was a mandated pediatric restraint device on all ambulances. And when I was conducting this research, I should say, we were in a system where it was not required. And the observation of that difference was kind of a stark one. And that was something that informed my thought, my approach to things. Identifying the scope of the problem in the first paper allowed us to kind of come up with some smaller or some additional aspects that we wanted to look at. And so the second paper came out of that as a means of looking at one of the elements identified through previous papers by other individuals who showed that individuals providing care in ambulances were concerned about the ability to give adequate life-saving measures to children in extremis.
You guys watched video footage of ambulances arriving at the children's emergency room for a year, and then checked to see if the safety restraints were used during the transport, like car seats. And so also taken into account were these the right ones for the size of the child, right? So is the child properly secured? So by doing this, they reviewed over 3,000 cases and matched each case with child's age and weight from their medical records. So I got really excited because just seeing the way that this come together, you're able to, find the reality. And so what was found was only 53.5% of kids were transported using the right type of safety device. And that's the right type of safety device for their weight. I also saw about 77% of safety devices were not used correctly. And commercially made pediatric restraints worked best, but were still not used properly half the time. I'm assuming you mean like PDMate kind of tools. Also, most ambulances used the ambulance cot for transport, but this was only the right choice in about 18% or so of the cases. And so this means that most children in ambulances aren't safely secured. And so that obviously we know could lead to serious injuries if there's a crash or even just during the time of the drive. And so we know that EMS teams do need better equipment and training to pull this off. And there is no national standard for how to safely transport kids in ambulances. And so out of this, you had mentioned that it's a really time now to put together new safety rules for ambulance teams and look at even the federal level maybe to do that. And also to reinforce that, hey, we have pediatric specific restraint systems already. After looking at this, I know that this hole that you were talking about at the beginning, that that you saw the data that was needed there for, I know that kind of thing comes out of frustration. I'll tell you right now that I have seen cases of people that got injured because they weren't properly restrained, and it's disheartening to work in triage and watch kids being wheeled in on a bed with no seatbelts at all. And I know you have seen that too. But one of the big things was that the study here, says, hey, we need federal standards for this. But how can I just ask you, how do you think that would make a difference? Tell me about your frustration. Look, that got you here. What do you think here?
Yeah, so it's a challenging topic because there, in general, in EMS hasn't been a tremendous amount of federal oversight, and a lot of things have been at the state level. And that has pros and cons, right? You have really robust states that do things very well, and you have states that don't do things very well. And you have a lot of states where it's kind of piecemeal. A lot of this, or pretty much all of this work was done in the Capital District, Capital Region of New York around Albany. And we have a wonderful, wonderful medical director there. I'm required to say that because he's Dr. Daly, but he, his guidance of a lot of these agencies has led to good standards and good approach. And yet it's still a lot of his agencies, and we're ending up with these numbers. And then I worked in areas in Massachusetts and New Hampshire where at one point I didn't even know who my medical director was.
Mm-hmm.
And yet the state had requirement to have a pediatric transport device on every ambulance, and it was better.
Mm-hmm.
I don't know how much better. There's no evidence, but I know that it was at least used. Was it used correctly? But those devices were utilized because they were there.
Mm-hmm.
And so having it was a very valuable or necessary, I should say, component of the process. And so a simple requirement, and I'm not saying that federal guidance on everything is the answer, or that putting mandates broadly are necessarily the best way to accomplish things. But I think that emphasizing the need to have some sort of ability to transport children safely is a must.
Mm-hmm. Yeah, because I think that we all know how these things happen. If folks don't pay attention now, then we see this coming, and some child is going to get killed, and there is going to be effort that gets put behind that to have some bill, create a law later down the. But why go through all that when we know this is a problem? We know that it's easy to see. So, what can we talk a little bit about, what some of the restraint systems that would be perfect for ideal use? Because right now, on my ambulance, I have a PDMate, and then I pretty much anybody that's bigger than that, I use the stretcher seat belts that create an X. And they're really good for bariatric patients also, but they are not the harness one, but the full X straps is what am I safe with my transports? Tell me more about this.
Well, you have kind of a gap in there. Your PD mate has a specific weight limit. The stretcher has a minimum weight limit, and because of that, you have these gaps. I think that there are a variety of devices, some of which have a broader scope of weight. So the PD mate and the neomate are kind of the typical ones that if someone has one, they almost certainly have that. They're the cheapest, they're the best known, they're probably the easiest to use, frankly. But there are a couple others. There's the ACR and the ECR. These are much less well known, quite a bit more expensive. And my personal feeling is a steeper learning curve, although that's just a personal opinion. There are built-in seats in ambulances. I know that I had a couple of those ambulances over the years, and there are some agencies that make a real concerted effort to have that built-in ambulance seat in the captain's chair. But that's only for a certain type of patient, and really that often ends up getting used for the child of a parent who is being transported, at least in my personal experience. And so what we really need is something else. And I don't know specifically what that is. The thing that comes to mind is something like the latch system in passenger vehicles. Become very familiar with that, having a child during this process of publishing these papers. But having something where the child safety seat can actually secure to the frame is important. Another simple thing is that we need to finally get rid of the yoke system of securing stretchers. I think that that's mostly gone now, but the older stretchers just had the yoke, and if the ambulance flipped, it flipped. Towards the end of my time on the road, you ended up having more of like a track system that it locked into, and that, at least in theory, would keep it in place if the ambulance rolled or flipped, but I have never seen it to experience it for sure. And so that is something that I think is important to emphasize, that how the stretcher itself is secured is also an important part. But I think that the frame of these stretchers themselves, absent specific crash data, the best bet is probably to secure it to the frame.
Yeah.
And I know there's plenty of people who try, they make a really good effort with lots of backboard straps, and I'd be lying if I said that I hadn't done this in the past, and you get all of the 9-foot straps you have and you make a spoon of strap to try to secure a child seat and drive really carefully. But that's not an answer.
Well, and the other part to this is that when a lot of folks that do use these pediatric transport devices might use the patient's own car seat, and when that gets strapped in, then, well, the technique for how that gets strapped in differs based on how who's doing it.
Right.
So obviously those aren't rated or created for those.
Right. There's no appropriate way to secure it to an ambulance stretcher. You can make a good faith effort, but that's really all it is. There are also, many of them are designed, well, depending on the age of the child, to be either rear facing or forward facing. And so you then have the fact that the stretcher is now facing the opposite direction of what you would expect. And so that changes how you're going to secure it. It's also designed for the latch system primarily, but also can be done with shoulder straps for older cars, but you don't have shoulder straps with a standard stretcher. And so maybe you could secure it appropriately in the captain's chair, but then it's quite difficult to assess the patient. And overall, there's just not a good way outside of a commercial device right now to do this. And I don't think any one brand is the answer. The PD Mate is a little bit on the small side from my experience, although I think it probably can be used a little for a little bit older patients than we typically do. And ultimately, I think that the answer is something that doesn't exist on the market yet. And I'm not a product designer, so I can't tell you exactly what the answer is, but I think that there's a big market if you're that kind of person to find and solve this problem.
Yeah, and some people are, folks may be in a position where they roll their eyes and say, "Oh my gosh, they're just being so ultra careful." But I just want to make a sidebar, notice to this, to tell everyone that I myself have been part of a child ejection from an ambulance because of an improper restraint. It was not my patient, it was not my ambulance, but I've seen this happen. It is so scary. So we think, about priorities. It just has to get mixed into the priorities, even if we're dealing with a burn patient or whatever. The other mentionable that I have about this, and I want to get your take on this, is that when I talk to parents, a lot of times I will advocate for using the car seat that is like the PD-Mate or the X straps, because I want to be able to watch the child breathing. And
Yes.
if you have that big old hunk of plastic around them, you just can't monitor them the same way. And, I've just done this long enough that I've had kids stop breathing in a car seat. And then I'm in a position of, second guessing myself and
Yep.
triple checking. And, why should I go through all that when I could have actually visualized if I had them in a restraint device that allowed me to do that to begin with? So if I have a respiratory patient, then that's another consideration. And it's like, gosh, why do we have to have kids ejected from ambulances? And why do we, have to have, these moments where you spend extra seconds evaluating, the respiratory issues? And it is a bigger deal than it seems at first.
Well, right. And as you mentioned, it will, the way it's going right now, it will take an accident involving child, grandchild, close acquaintance of someone significant in some capacity, and you end up with a named law. I'm very tired of named laws.
Right.
And you'll end up with a tragedy that ends up making a difference. But let's make a difference before there's a tragedy. It's admirable to take these sad stories and turn them into growth and change, but it's even better if we can do that beforehand.
Yeah. And that's why you're doing stuff like in this next study. You also put out something in pediatric emergency care. This was from 2024, called Children in Restraint Study in Emergency Ambulance Transport and Cardiopulmonary Resuscitation, Car Seat CPR and Observational Cohort Study of a Simulated Pediatric Cardiac Arrest. And so this study explored how well EMS workers can provide those BLS skills on kids and infants inside the moving ambulance. And so it also looked at whether the way the child is secured actually affects how well those skills were performed. And so what I noticed is that you all in that research team tested the EMS workers' ability to do CPR and give breaths to child and infant mannequins during a simulated cardiac arrest. And the tests were done in a moving ambulance on a closed track. The mannequins were either secured to stretchers in different ways or left unrestrained. And 24 EMS workers took part in these simulations. What the study that you did found was that for children, there wasn't any big difference in the quality of CPR and whether they were restrained or not. And then for infants, there was a slight difference in the depth of chest compression, but it wasn't necessarily clear if that had any real impact on safety. Neither group, the children or infants, neither one of them showed improvement in ventilations while restrained. And they were really highlighting at the end that for infants, you found that CPR was not adequate, and no matter how folks secured these little kids. And so that's a pretty big wake-up call. Everything in the moment. You know how there are some providers that have this philosophy of, oh my gosh, I have a baby not breathing, let's race them somewhere to get help, instead of doing all the actions necessary right then and right there, so that the transport might be delayed because these other interventions would be more necessary. Of course, I'm not talking about trauma cases or immediate surgery intervention needed cases, but tell me about these findings, especially what the shocking ones. And then does that have any, does this add to any consideration of the fact that we should be doing more on scene and less during transport? Tell me what you think.
Yeah, I mean, I think that a lot of what I've found, or a lot of what I've been looking into, has been based on studies by O'Neill and Fittacaro. Both, actually, one was PEC, the same journal, and one was Clinical Pediatrics, both 10 years ago, something like that. But one of the big findings there in those survey-based studies was that providers were concerned that securing a child safely or aggressively or appropriately, or however you want to phrase it, would limit their ability to perform life-saving interventions. That was the impetus for this paper. And so frankly, I didn't expect to find the answer that overall CPR was just inadequate in general in a moving ambulance. In retrospect, it makes perfect sense. But what we were seeking to show was that securing them appropriately did not adversely impact quality of resuscitation. And we found that. But we also found that in motion, you can't appropriately perform CPR. And like you're talking about, I think that in most situations, it probably doesn't make sense to attempt CPR in a moving vehicle. And this is probably the case in adults too, although I haven't performed the research specifically on the adult patients, but I believe that there is some as well. In most cases, if ROSC has not been achieved on scene, return of spontaneous circulation has not been achieved on scene, it's probably not going to happen. It's certainly not going to happen in an ambulance, and it's probably not going to happen. Goodness only knows how long it will take you to get to the hospital. There are certainly situations where it makes sense to go quickly to the hospital. We had one when I was in medical school where there was a cardiac arrest from some kind of congenital heart defect 3 minutes away from the hospital. They got them to the hospital. He ended up getting a pacemaker, I think, and did great. That's the exception rather than the rule, right? That's a 14-year-old who drops from something weird. This is not a 3-year-old not breathing. This is not a baby who is having trouble breathing and ultimately goes into a respiratory and then cardiac arrest. That's the majority of these patients. And in those patients, if you're not getting them back on scene, it's very, very unlikely that you're going to get them back elsewhere because there's not anything additional that I'm doing. Yes, I may be more able to intubate the child than you are on the floor in a bedroom in a third floor apartment. But what I'm not doing is anything meaningful beyond what you have the capacity to do. BLS airway has been shown in almost all cases to be equal to advanced airways. If you are adequately bagging, and the vast majority of children, you are going to be able to, using BLS airway methods, provide adequate ventilation and oxygenation. If you are doing that with good compressions and having a defibrillator available, that is almost everything that I am going to do. It is almost entirely BLS. Add epinephrine, the value of that's a topic we can have that conversation another day. But there's very little additional value given from being in the hospital, other than having a number of people and a number of resources from the social side of things. And so I am not necessarily advocating for just terminate on scene, but I think that the idea that you are making an aggressive move to the hospital because that is what is going to be the best outcome for the patient, that is just generally speaking not the case.
And I'm thinking about these other things that are at play. Sometimes you have emotional family members and their emotion adds to the ruckus on scene that prevent you from doing the interventions that you need. And so I'm not saying me, I'm just thinking about, these cases are very dramatic and very unfortunate sometimes. And so if you have family members that are screaming at you to a near violent state, because in their mind, the answer is with the doctor. In their mind, this has to get fixed. And the only way to fix it is that ambulance, because of whatever they perceive. And so, I'm glad we could talk about this because the big difference in my 25 years or whatever, looking at PALS and Tevi's program for pediatrics is just, that's one of the big steps that I changed in my own practice is that instead of trying to get that kid to the ambulance, I will drop everything and do everything in the exact moment I can, so as soon as I can, there is no time to take extra time running with the kid to do something. No, you have your equipment, do your work right now. And so this research study just in some kind of ways reinforces the fact that, there is a job that we have to do, and it can't be shifted to someone else who's not able to make any interventions. And I guess that's part of what being a paramedic is about, is making educated decisions about, what interventions do I need to make based on the H's and T's that I have, and are there H's and T's that I can't fix that I need someone else to fix for me? And So this is pretty incredible. When you add up these things to look at the situation in its complex form. So
The one thing I want to add just is that, I had the opportunity to go out to Seattle for Resuscitation Academy quite a few years ago now, and that was just a wonderful experience. And the thing, it's very silly, but that I take away is one of the mantras for Medic One is every cardiac arrest you go in with a backboard because everybody survives. Obviously, that's not the case, right? For overall cardiac arrest survival, you're talking 8% nationwide. But having that mindset, having the idea that every cardiac arrest you go to, you're going to extricate, you're going to get to the hospital, that actually makes a difference. And it's crazy that it does, but it's actually been shown multiple times over to make a difference.
Well, it's the mindset. It's the putting the focus in the right places. It's all part of the things that can make things go well. And some of that is experience, and other parts of that come from, well, the kind of work that you do. So it's great. This study connects with the other one that we talked about earlier about how children are transported in ambulances. And that first study showed how kids are often not properly secured, and that puts them at risk for these crashes during the ride. And the second study added another concern. It shows that even when restraints are used, they don't necessarily help us perform like these life-saving skills that, like CPR, especially we found out for infants, it may not be as effective during that trip. So together, these studies do highlight the challenges that EMS teams face when we work to safely transport and treat kids. And so there's a clear need for better equipment, training, and safety standards to protect young patients and ensure the proper care during emergencies.
The other thing is you talked about the value there, but the danger to EMS providers, right? It is very difficult, and one of the things that I wanted to look at and we weren't able to with the study design is to see the efficacy of compressions with providers properly secured. And if they're not doing it with just the patient properly secured, we did not give any instructions on what they should be doing, whether they are straddling the patient, whether they're sitting in the captain's seat, whatever. And so that is something that it can't be overlooked, that there's real danger to the people providing care, right? We emphasize scene safety, right? It's almost a joke at this point that scene safety BSI, right? That's the first thing we think, but it's a really critical component. And it's something that we didn't have data specifically to support, but that we really wanted to emphasize that none of our providers felt safe doing this. We were on a closed course. There was really no risk at the 10 miles an hour we were going, but none of them actually felt comfortable or safe doing this. And they were willing to do it because you save a child, but it's not the best thing for anybody.
Yeah. And so we have these automatic devices to help with adult CPR, but if they're too big or too small, then it's just hands-on only. Like many of you, I'm also an EMS instructor, so I know what it's like to have topics that are important to cover, but are not actually in your curriculum. So when it comes to EMS research, I want you to know that I've been joining EMS classes lately in a virtual kind of way. It's fun for me to meet your students and talk about EMS research, or even talk about how things are done differently where I am versus where you are. So if you're an EMS instructor like me and you want to give your students a flair of what EMS research is all about, just fill out the inquiry form on my website at professorbram.com. This is professorbram.com, and I'll be in touch. I want to also invite you to check out my latest book. I co-authored it with 4 Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis.
We've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others, no matter how self-reliant we are. If we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but I don't care how much skill you have. There's very few people who would be able to not say, "Oh my gosh, I need help," and then all of a sudden someone shows up
with a badge.
Yeah. And you think, well, maybe this is someone that can help. Well, you said that, and I said that, during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state.
I want to invite you to check it out because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient who's in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. Follow a link there below to find it, or you could get it almost anywhere books are sold. And if you contact me, I would be happy to mail you an autograph sticker designed to be put into the jacket cover.
Hi, I'm Will Chapleau from the International Pre-Hospital Medicine Institute. You might know about us because of the literature reviews that we post every month free for your review on our website at iphmi.com. and also published through GEMS Online Magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field, or what we should be doing in the field, or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here. And they're all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials, relevant information, affordable information, and an access so you can get to it. So if you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call. Go to my website and fill out the form. It's at professorbram.com, professorbram.com. I just want to thank you for listening, and I look forward to sharing more insights with you in the next episode. If you enjoy EMS research, please tell your friends and like, share, and subscribe to help others get the message.